Everyone, welcome to this explainer. Today we're unpacking the absolutely fascinating biochemical pathways of jaundice, and we're going to do it by looking at a high-stakes, real-world medical emergency. Now, for those of you grinding away studying for the United States Medical Licensing Exam, or USMLE, consider this your ultimate high-yield review of bilirubin metabolism. We are going to cover every major disease, every crucial enzyme, and literally all the classic buzz points you're going to need to know to ace those questions.
Okay, let's dive right in by starting with the absolutely terrifying case of Bruce Phillips. So Bruce is a 74-year-old guy who went in for what should have been a standard laparoscopy-assisted partial excision of his ascending colon for a CT1N0M0 stage tumor. Because the surgeons encountered multiple adhesions, he lost a significant amount of blood during the procedure and ended up needing a transfusion. Now, Bruce's blood type was O-Rh positive. But in a catastrophic medical error, he was accidentally transfused with type B Rh positive blood. Within just 17 minutes of this ABO-incompatible transfusion starting, his blood pressure absolutely plummeted. We're talking 150/70 all the way down to 90/40 millimeters of mercury. At the 7-hour mark, his hemoglobin had dropped to a critical 5.8 grams per deciliter. His lactate dehydrogenase spiked to 710 units per liter, and his haptoglobin severely dropped. Make no mistake, this is the classic textbook presentation of an acute hemolytic reaction. And physically, just 2 hours after that transfusion began, his entire body started to turn yellow.
Within just 2 hours of his red blood cells breaking down from that mismatched transfusion, Bruce's eyes and skin turned a startling bright yellow. This condition is known as jaundice, or icterus. Now here's a really interesting clinical pearl. Mild hyperbilirubinemia is actually completely undetectable to the naked eye. You only start to see this yellow-orange discoloration in the skin, the conjunctiva, and the mucous membranes when plasma bilirubin concentrations exceed a very specific threshold of 2 to 2.5 milligrams per deciliter. In Bruce's case, his unconjugated bilirubin shot up to 3.4, rapidly pushing him well over that visible threshold.
To really wrap our heads around why Bruce turned yellow so fast, and honestly, to master this entire topic for your medical exams, we need to stop thinking of the liver as just an organ and start treating it like a highly organized metabolic processing plant.
This biological factory is entirely dedicated to handling bilirubin, and bilirubin is simply the waste product created when old, worn-out red blood cells are dismantled by the reticuloendothelial system in your spleen, your bone marrow, and the hepatic Kupffer cells. Normally, this factory is incredibly efficient, processing close to 250 to 300 milligrams of bilirubin every single day. This entire biological supply chain has 3 very distinct phases, and a dysfunction in literally any of these is going to lead to jaundice. First up, we have the prehepatic phase. Think of this as the shipping of raw waste to the factory. Second is the intrahepatic phase, where the liver cells actually process the material on the assembly line. And third is the posthepatic phase, where the finished product is exported out of the body. Keeping these 3 distinct phases organized in your mind is absolutely crucial. It is the key to diagnosing the underlying cause of any patient's jaundice.
So let's zoom in on the exact machinery inside a single liver cell, the hepatocyte. Pay attention here because this is incredibly high yield for the USMLE. First, unconjugated bilirubin is brought into the hepatocyte via facilitated diffusion. Once it's inside the cytosol, it immediately binds to a protein called glutathione S-transferase, or GST. This is important because GST basically acts like a molecular anchor, preventing the bilirubin from just leaking right back out into the blood. Next, it moves over to the endoplasmic reticulum, where a highly testable enzyme called UGT1A1 conjugates the bilirubin by attaching it to glucuronic acid. Finally, this newly conjugated bilirubin is actively secreted into the bile canaliculi using a special energy-dependent transporter door called MRP2. Burn UGT1A1 and MRP2 into your memory. They are going to come up again very soon.
The whole point of that factory assembly line is to transform the bilirubin. You really have to understand the difference between the raw material and the finished product. Unconjugated bilirubin, the raw stuff, is fat-soluble. Because it's not soluble in water, it can't just float freely. It has to be bound to albumin to travel through the bloodstream. And crucially, because it's bound to albumin, it absolutely cannot be filtered and excreted by the kidneys. Conjugated bilirubin, on the other hand, is the finished product. It's had 1 or 2 molecules of glucuronic acid attached to it by our good friend UGT1A1. Think of that glucuronic acid like a water-soluble handle. This means conjugated bilirubin can be safely excreted into the bile, Or, and this is a big deal, if it ever backs up into the blood, it is water-soluble enough to be filtered out by the kidneys straight into the urine. Alright, so with that factory model in mind, we can basically map every single medical cause of jaundice into 3 distinct buckets. Prehepatic jaundice is driven by an overloaded supply of bilirubin or decreased uptake at the factory doors. Hepatic jaundice happens when the internal machinery itself is broken, leading to decreased conjugation or just generalized cellular dysfunction. And posthepatic jaundice occurs when the export pipes are blocked, which clinically we refer to as cholestasis. Let's break down each one of these buckets in detail.
Let's kick things off with the first bucket, prehepatic overload. This is what happens when you simply have too much raw material. Prehepatic jaundice occurs when the body destroys red blood cells way too quickly, a process called hemolysis. This dumps a massive, overwhelming overload of unconjugated bilirubin onto the liver factory all at once. The liver is trying its best, but it simply cannot conjugate this massive volume fast enough. The result? Greatly elevated serum levels of unconjugated bilirubin, where the conjugated fraction remains less than 20% of the total. This supply overload happens in a variety of classic board scenario ways. It happens during acute hemolytic transfusion reactions, which is exactly what happened to Bruce Phillips during his mismatched ABO transfusion. We also see it in inherited hemolytic disorders, think sickle cell anemia and hereditary spherocytosis, or acquired ones like autoimmune hemolytic anemia and malaria. It's also seen in ineffective erythropoiesis conditions like vitamin B12 deficiency or thalassemia, where the red blood cells just undergo apoptosis right there in the bone marrow. And of course, we see this heavily in neonates. Physiologic jaundice of the newborn happens because babies naturally have a high turnover of fetal red blood cells, combined with immature hepatocytes where that UGT1A1 enzyme activity is only about 1% of an adult's. Then, there's hemolytic disease of the fetus and newborn, or HDFN, where maternal IgG alloantibodies, very often from Rh incompatibility, cross the placenta and systematically destroy fetal red blood cells, causing extreme anemia and massive hyperbilirubinemia.
Now, what's really fascinating and incredibly dangerous about this prehepatic overload in infants is what happens if that unconjugated bilirubin builds up too high, specifically over 20 milligrams per deciliter. At that level, it becomes highly neurotoxic. Because newborns have naturally low albumin levels, a lot of this fat-soluble unconjugated bilirubin just floats around unbound. Because it's lipid-soluble, it can freely cross the infant's poorly developed blood-brain barrier and bind to lipids right in the brain tissue. This causes a devastating, permanent condition called kernicterus. If you were to look at an autopsy, you'd actually see a distinct yellow discoloration of the basal ganglia, the thalamus, and the hippocampus. Clinically, kernicterus results in severe extrapyramidal dystonia, hearing loss, and oculomotor palsy. It is an absolute code red medical emergency.
Okay, moving on from supply issues, let's look at the second category, hepatic failure. This is when the factory machinery itself breaks down.
Hepatic jaundice happens when the incoming supply of red blood cells is perfectly fine, normal levels, but the factory machinery is broken, inflamed, or maybe genetically deficient. This leads to what we call a mixed hyperbilirubinemia, where you have a mix of both the raw unconjugated and the finished conjugated bilirubin leaking back into the blood. In these specific cases, that conjugated fraction is typically going to sit somewhere between 20 and 50% of the total bilirubin. Usually this broken machinery is caused by acquired inflammatory damage. Think of things like viral hepatitis, toxic hepatitis, autoimmune issues, or alcoholic liver disease. When a virus replicates in the cytoplasm of a hepatocyte, the cell's physical function gets totally distorted. Uptake and conjugation decrease, which raises your unconjugated bilirubin. But at the exact same time, liver cell necrosis and the disruption of tiny bile ductules allow the already conjugated bilirubin to leak freely back out into the bloodstream. And a major diagnostic clue here? Because there is active, ongoing damage to the hepatocytes themselves, you will predictably see a spike in the serum liver enzymes ALT and AST. But hepatic failure isn't always caused by inflammation. Sometimes it's just genetic. Comparing these genetic defects side by side is a massive point for the USMLE. Both of these involve our old friend the UGT1A1 conjugating enzyme. First is Gilbert's syndrome. This is an autosomal recessive mutation in the Tata box promoter region of the UGT1A1 gene. It is incredibly common, affecting up to 12% of the population, and it's completely benign. People with Gilbert syndrome have about 30% of normal enzyme function, so they only really experience mild jaundice when the body is stressed, like during fasting, illness, or heavy exercise. On the far end of the spectrum, you have Crigler-Najjar syndrome type 1. This is a rare autosomal recessive disorder where there is an absolute complete lack of UGT1A1 activity. Total unconjugated bilirubin shoots past 20 to 50 milligrams per deciliter right after birth. It is universally fatal without aggressive phototherapy and exchange transfusions, quickly leading to that kernicterus we talked about earlier. Now, don't confuse this with type 2 Crigler-Najjar, where enzyme activity is just less than 10%. Type 2 can actually be treated with phenobarbital to induce the remaining enzyme. But remember, phenobarbital does absolutely nothing for type 1 because there's simply no functioning enzyme left to induce.
Finally, let's talk about the third bucket, posthepatic blockage. This is all about the blocked pipes, otherwise known as cholestasis.
In posthepatic jaundice, the liver factory is actually working beautifully. It takes in the raw material, it hums along, and it successfully conjugates to bilirubin. But then, the export pipes are blocked. This severely decreases bile flow, literally forcing the conjugated product backwards into the bloodstream. Because this blockage happens after the processing phase, the conjugated bilirubin fraction here is going to be strictly greater than 50% of the total serum bilirubin. Now, these blocked pipes can be literal extrahepatic physical obstructions. Classic examples include cholelithiasis, which are just gallstones stuck in the common bile duct, or a carcinoma at the head of the pancreas that grows large enough to externally compress the bile duct. They can also be intrahepatic obstructions, things like primary biliary cholangitis or primary sclerosing cholangitis, which progressively destroy the bile ducts from within the liver. And finally, we have some rare genetic mutations where the specific cellular export doors simply don't function. Let's look at what these obstructions actually do to the tissue.
If you were to look under a microscope when these pipes back up and cholestasis sets in, you'd see a few classic hallmark signs. On one hand, you get canalicular cholestasis, which is characterized by these brownish biliary plugs. These are inspissated, thickened masses of biliary material that are literally choking the dilated bile canaliculi. You also see what's called feathery degeneration. Because bile acids are also retained right along with the bilirubin, they start to literally poison the liver cells from the inside out. The hepatocytes swell up, gain a pale, foamy, net-like appearance, and undergo necrosis. Clinically, your big buzzword marker for this kind of biliary obstruction is a disproportionate rise in alkaline phosphatase, or ALP, and GGT compared to AST and ALT.
Now let's talk about one of the most visually striking and heavily tested genetic blocks on the boards, Dubin-Johnson syndrome. This is an absolutely fascinating benign autosomal recessive disorder. It's caused by a mutation in the ABCC2 gene, which completely knocks out that MRP2 export door on the canalicular membrane we talked about way back at the start. Because MRP2 is locked, conjugated bilirubin is forced to escape back into the blood via an alternative backup door called MRP3. The ultimate buzzword here is the gross pathology. The patient's entire liver turns pitch black, literally black. This happens because metabolites of tyrosine, phenylalanine, and tryptophan can't be exported into the bile, so they polymerize into a dark, melanin-like pigment right inside the hepatocyte lysosomes. Another massive diagnostic marker here is the urinary coprolporphyrin ratio. Normally, the ratio of coprolporphyrin I to 3 is about 25 to 75-45. In Dubin-Johnson, this ratio is completely flipped.
You definitely need to compare Dubin-Johnson to other rare genetic blockages, like Rotor syndrome. Rotor syndrome is also a benign condition that causes conjugated hyperbilirubinemia, but it's due to mutations in the OATP1B1 and OATP1B3 transporters. The big difference? A patient with Rotor syndrome has a completely normal-looking liver. There is no black pigment at all. Furthermore, if you do an oral cholecystography, the gallbladder will visualize normally in Rotor syndrome, but it will fail to visualize in Dubin-Johnson. Then there is progressive familial intrahepatic cholestasis, or PFIC, and this one isn't benign at all. It represents a group of 3 specific mutations, ATP8B1, BSEP, or MDR3, that lead to severely defective secretion of bile acids and phospholipids. PFIC patients suffer from early-onset childhood cirrhosis, intense severe pruritus, and watery diarrhea. Why the diarrhea? Because without bile acids reaching the gut, they simply cannot absorb dietary fats.
So what is the ultimate takeaway for decoding these clinical symptoms? It relies almost entirely on tracking the color. Normally, conjugated bilirubin travels into the intestines, where gut bacteria turn it into urobilinogen and eventually stercobilin. That stercobilin is what gives feces its normal brown color. A small amount of that urobilinogen is reabsorbed and excreted by the kidneys. Now, in prehepatic hemolysis, you get massive amounts of urobilinogen being produced, which means you get dark feces and normal-colored urine. But in posthepatic cholestasis, the pipes are blocked entirely. No bilirubin is reaching the gut, which means absolutely no stercobilin is made, resulting in striking, pale, clay-colored stools.
Meanwhile, all that conjugated bilirubin backs up into the blood. Because it's water-soluble, it gets aggressively filtered by the kidneys, resulting in very dark, tea-colored urine. Furthermore, the buildup of bile acids backing up into the blood and depositing in the skin acts as a powerful pruritogen, causing intense, generalized itching across the patient's body.
Which brings us to our final puzzle for you to solve today. Imagine a patient walks into your clinic complaining of intense, generalized itching. They tell you their urine looks like dark tea and their stools are unusually pale. Based on everything we've just traced through the liver's biological factory today, which specific phase is broken down? Is it the prehepatic supply, the intrahepatic machinery, or the posthepatic export? Keep this factory model in mind, look at the colors, and you will never struggle with the mechanics of jaundice on your exams again. Let us know your diagnosis in the comments below, and keep studying hard.